So without any further delay, I'd like to introduce Dr. Christina Del Guzzo. She is a dermatologist here at Weill Cornell Medicine, and I'd like to turn the speaker over to her.
Thank you so much, Dr. Pavlik. Good evening, everyone. I'm just going to go ahead and share my screen. Okay, so tonight I'm going to be talking to you guys a little bit about the way that skin cancer prevents and the way that we treat it, and specifically focusing on non-melanoma skin cancer. So as a brief overview of my talk, we're going to first start and go over the basics of skin and skin cancer, and then we'll cover how the three types of non-melanoma skin cancer are treated. So those include basal cell, squamous cell, and Merkel cell carcinoma. And if time permits, we'll go through some skin cancer prevention tips. So starting with a brief overview of the skin. So the skin is made up of three main layers. The top layer is referred to as the epidermis. The second layer of the skin is referred to as the dermis. And then the layer below that is subcutaneous tissue, and that's largely fat. So most skin cancers actually arise in the top layer of the skin, which is the epidermis. And this is the layer that's exposed to the sun. And then they can invade deeper into the dermis. The way that skin cancers are treated in part depends on how far they go into the skin. So what is skin cancer? So skin cancer is an abnormal growth of skin cells. Normal skin cells are impacted by genetic changes induced by a variety of causes, the most important of which is the sun's rays. The sun causes genetic changes that affect the way that our cells function, especially how they grow and divide. So when enough genetic changes occur due to this sun exposure, most often, this leads to rapid and uncontrolled cell growth in the formation of a cancer cell. And then as that uncontrolled growth continues, it can form a tumor. As I kind of alluded to, 90% of non-melanoma skin cancers are associated with exposure to the sun's rays or the UV radiation from the sun. And so unsurprisingly, most skin cancers develop on areas exposed to the sun. And skin cancer can affect people of all races and ethnicities, although those with light skin who sunburn easily have a higher risk. And then, so non-melanoma skin cancer these are the most common of all types of cancer. So cancers of the skin are the most common types of skin cancer, the most common types of all cancer. So the two most common types of non-melanoma skin cancer are basal cell carcinoma and squamous cell carcinoma. And by one estimate, there are about 5.4 million basal cells and squamous cells diagnosed each year, with the vast majority of these being basal cells. And so the main difference between basal cells and squamous cells, basal cell carcinoma and squamous cell carcinoma, is really the cells that they arise from within the skin. So basal cells arise from this bottom layer of the skin, the bottom layer of the epidermis, which is the top layer of the skin, and squamous cells arise from squamous cells, which live in a different part of the skin. So I wanted to start by talking about basal cell carcinoma. So as we mentioned, this is the single most common cancer in humans. It's due to UV exposure from the sun, and therefore occurs most commonly on sun-exposed skin. It typically has its onset in the 60s or 70s, but depending on the sun exposure history of the person, it can be earlier. And it typically has a fairly slow and non-aggressive growth. And if you take away one thing from basal cell carcinoma, or my talk on basal cell carcinoma, it's that oftentimes they look like this, like they look pearly and shiny and translucent. And they have very, very, very low potential to spread beyond the skin. And we usually just see them within the skin. But the problem with basal cells is that they can be locally destructive, as you can see in this picture. So they can cause a lot of damage locally in the skin. So they still, even though they don't typically spread beyond the skin, they still are worth treating because they can be locally destructive. So there are a couple of different types of basal cell carcinoma. So superficial basal cells involve only that top layer of skin, or the epidermis. And they're about 15% of all basal cells, and they usually happen on the trunk, the torso. And they typically present with thin pink plaques or lesions that are kind of broad and thin. And they can sometimes have like a pearly hue to them. As you can sort of see in this picture, it's kind of shiny. And then sometimes they can also, they can be thin and have more of just a pearly border, as you can see in this picture. And then nodular basal cells make up about 60% of basal cell carcinomas, and these are most common on the head and the neck. And so it's a painless growth of the skin that again has this shiny, pearly, translucent look to it. And oftentimes, as you can appreciate in this picture, you can see some blood vessels running throughout it. They can sometimes form small wounds called ulcers or ulcerations as they progress. And then they can also have areas of pigment within them. And the pigmented basal cells are actually a common type that are seen in darker skin types, but can be seen in lighter skin types as well. And then they can also develop these kind of pearly rolled borders, which is a classic presentation, but it has this ulceration in the center and these kind of rolled, pearly, shiny borders. So just different presentations of basal cells. And then finally, I wanted to talk about a much less common form of basal cell called a morpheaform basal cell. And this is very uncommon, but it tends to be one of the more aggressive subtypes of basal cells, and it looks and appears like a scar, but it's actually a skin cancer. The reason I bring this subtype up is because if you develop a lesion that looks like a new scar, but you don't recall trauma to the area, especially on the face, this is something definitely worth bringing up to your doctor. And moving on to squamous cell carcinoma. This is, unsurprisingly, the second most common type of skin cancer and overall cancer that exists. It arises in chronically sun-exposed skin. So similar to basal cells, can cause local skin destruction and disfigurement. And it's important for us to diagnose and treat these early to prevent them from spreading within the skin, but also from spreading to other areas of the body. Squamous cells can metastasize or spread to other areas of the body more often than basal cells, but it is still quite rare for them to do this. Most of the time, these are just localized to the skin. So as we've discussed, the sun is the biggest risk factor for squamous cell carcinoma, but there are some other things that put people at risk for squamous cell, as well as other cancers. But a suppressed immune system is one of the major risks. So organ transplant recipients have a 65-fold increased risk for squamous cell carcinoma compared to the general population. And then other certain types of leukemia, certain types of chemical exposures, even chronic wounds or a radiation treatment field. These can also be risk factors. So unlike basal cells, squamous cell carcinoma arise through a series of progressive stages. So they start out often as a precancer known as an actinic keratosis. They then progress to a superficial squamous cell carcinoma, which just involves that top layer of the skin called the epidermis. These are referred to as squamous cell carcinoma in situ. And then finally, they can progress to invasive squamous cell carcinoma, which involves both layers of the skin, the epidermis and the dermis. So I wanted to talk a little bit more about these precancers because they can be quite common. They often present as dry, scaly, or sometimes I refer to them as gritty. They have like kind of a gritty feel to them. And they're usually pretty flat spots that develop on sun-exposed skin. So commonly the face, neck, scalp, hands, and forearms. And the rate of progression to invasive squamous cell carcinoma is low. It's less than 1% per lesion per year. You can see this man here in this picture has numerous of these precancers. So overall, his risk of squamous cell is going to be higher, but each individual lesion has a very low risk of turning into squamous cell, and not every actinic keratosis is going to turn into a squamous cell. And then as we get a little bit deeper, then you get when you have the full epidermis involved, it's called a squamous cell carcinoma in situ or superficial squamous cell. And these tend to be thin, scaly, pink, broad growths. And then you can see here, there's a little bit of crusting. It's kind of broad and thin. And then when we get to invasive squamous cells, meaning involving both layers, the top layers of the skin, the epidermis and the dermis, they tend to be a bit more raised, have a little more substance to them, and they can be scaly, rough, pink raised growths. Here's another example. And they can grow quite large and develop, thick crust to them. And I show a picture of both the lip and the ear, as the lip and the ear are particularly high risk sites for developing. So if you develop a squamous cell carcinoma here, these are considered slightly more aggressive skin cancers. You can see that the spot here on the lip it's scaly, but it almost has like a warty appearance to it. And then the spot on the ear is kind of this kind of thick raised growth. All right, so moving on to how we treat these spots. So starting with the precancers, which are pre-squamous cell, if they're localized, we can freeze them off using liquid nitrogen, and we refer to this as cryotherapy. This is good for individual lesions or just a handful of precancers. And the benefit to this is it's super quick and easy. This can be done during a total body skin exam with your dermatologist. Usually there isn't any mark from the treatment, but sometimes, especially in darker skin types, you might be left with a lighter dark mark at the area of the treatment, or even a scar, but it's uncommon to scar. So this is the canister you'll often see if you go to the dermatologist. And then basically your dermatologist will spray liquid nitrogen, which is very, very cold, on the precancerous lesion for a few seconds, let it thaw, and then treat it for a few more seconds. It does sting because it's very, very cold. And usually this is a picture of what it looks like. The bottom picture is what it looks like right after treatment. So you can actually see it kind of freezes the spot. And the precancers are killed in the process of both the freezing and the thawing. So this spot on this person would probably have been a little bit red, maybe formed a little bit of a crust for a few days, even a week. And then the skin cancer would ultimately resolve and go away. So what happens when someone's whole face is covered in these actinic keratoses or there's these precancers? So we can't go after them individually. We have to do what we call a field treatment, where we treat whole areas of the face to get rid of these precancers to prevent them from turning into squamous cell. So there's a couple ways that we can do this. There's both topical therapies that patients can do at home, as well as in-office procedures. So I'll talk about two topical therapies that we use pretty commonly. One of them is called 5-fluorouracil, or Effudex, is the brand name. And this one is a topical chemotherapy. So it goes after those rapidly dividing precancerous and cancerous cells. And then the other is imiquimod. The brand name is Aldera often. And this is an immune activator. So what this does is it activates your local immune system in the skin to go after those precancerous cells and try to destroy them. And so both the chemotherapy and the topical immune activator, they both create a lot of redness, crusting, inflammation, and irritation. And that's sort of an expected response. That's how we know they're working. So there's a fair bit of downtime to both of the procedures, but they can be quite effective. So this is a picture of a man's forehead. If you look at his before treatment, you can see he has a lot of these scattered precancers. And so 1 week into treatment with the topical chemotherapy 5-fluorouracil, you can see that he's got some redness, some crusting of some of these spots, which gets much worse by the end of the 4th week of treatment, which is the end of the treatment. You can see he's very red, crusty, but by 3 months after treatment, all of his precancers are gone and his forehead looks great. So it is a process, but it does work. Some of the in-office procedures include photodynamic therapy, which I'll talk a little bit more about, chemical peels, and laser resurfacing. So photodynamic therapy is one of the more common in-office procedures for actinic keratoses or precancers. And basically it involves the application of a light sensitive cream or topical medication to the areas that are going to be treated, followed by exposure to a light source. And the combination of the photosensitizing medication and the light source leads to the death of the abnormal precancerous cells. So you can see that this is an example of what it kind of looks like in office. The benefit is it's all in office. It's usually only 1 or 2 treatments, and then you're kind of done. You don't have to apply a cream at home. The con is that the actual treatment itself can be quite painful. And oftentimes you are still really kind of red and crusty even after this treatment as well. And then moving on to how we treat superficial or low risk skin cancers. So we can use, for superficial skin cancers, we can use the same topical treatments we use for those pre-cancers, including the imiquimod or 5-fluorouracil, but oftentimes we need to use them for longer treatment courses than we would if we were just treating pre-cancers. And then the most common treatment that we use is something called electrodesiccation and curettage, or ED&C, and then sometimes we will also cut them out with surgical excision. So what is ED&C? Or electrodesiccation and curettage. This is a procedure that we do in office to remove low risk skin cancers and precancers on the trunk and extremities. So basically what we do is we scrape the area that's been confirmed a skin cancer with a sharp tool called a curette, which is shown in the bottom left here. And we scrape it until we feel like we've gotten the skin cancer off. And then we burn the base with this device on the right, which is basically just a heat stick that both helps to control the bleeding from the procedure and also destroys any kind of remaining tumor. And then this can be repeated a few times until the physician is confident that they've removed the entire lesion. So the benefit of this is it just takes a few minutes. It's really simple and quick. The downside is that we're just scraping the tumor off. We're not sending it for confirmation that we removed the entire tumor. So we don't get a pathologist to tell us under the microscope that the entire tumor is removed. But again, we're using this for lower risk tumors. The other downside is that, it does create a full circular scar. And so the cosmetic results of this procedure can be variable. So we usually don't do this one on the face. This is more for the trunk and the extremities. And then finally, moving on to how we treat invasive skin cancers. So sometimes we can use electrodesiccation and curettage, but more frequently for invasive skin cancers, we do some sort of surgery. So maybe that's a surgical excision or Mohs surgery, and I'll talk to you about the difference in a minute. And rarely we use radiation. So for surgical excision, the indications for this are a tumor really on any location with a well-defined border. So once we diagnose a skin cancer, especially an invasive skin cancer, we would numb the patient up. This is all in office. And we would numb the patient up, draw a margin of normal tissue around either the scar or any visible remaining tumor. And then we draw triangles on either side, which you can see depicted on this image. And this creates an ellipse. And so this ellipse of tissue would be removed. This is the entire ellipse would be removed. And the actual ellipse itself, or creating an ellipse, allows for the wound to be closed in a straight line. And so in this case, once that whole ellipse of tissue is removed, the surgeon goes in and puts in deep stitches that are usually dissolvable and take a few months to dissolve. And then they put in top stitches, which are usually removed within 10 or 14 days of the procedure. And then that tissue is sent for confirmation that the entire tumor was removed. And the benefit of this is that it, creates a linear scar, a line scar, which can often have a better cosmetic result or be less noticeable than the circle that is usually formed with the electrodesiccation procedure. Patients often ask me, how deep do I have to go? And the answer is we usually, for non-melanoma skin cancers, go to that very top layer of fat below the epidermis and the dermis. So we do try to take out both, because again, we're using this to treat mostly invasive skin cancer, so we want to make sure that we got below it. The main disadvantage to the surgical excision are that it carries, it's a small surgery, so it does carry some surgical risks like bleeding and infection, although these are or the risk of these is quite low. And you do sacrifice some normal tissue in the process. And then finally, the Mohs surgery is a special type of dermatologic surgery that has specific indications. So we often use it for recurrent skin cancers or skin cancers that have come back after their initial treatment. We use it for skin cancers that are more high risk. So oftentimes head and neck skin cancers are high risk, and we also use it on the head and neck because they're also cosmetically sensitive areas, meaning we don't want to leave people with big, huge wounds on the face. And then we also use it in areas where we're trying to preserve as much tissue as possible, because there's not a lot of extra tissue to work with, meaning like the fingers, the toes, and the genitals. And then Mohs is also indicated for some higher risk skin cancer subtypes and for larger tumors. So the benefit of Mohs surgery is that it has a very high cure rate, and it minimizes the actual normal tissue that has to be removed. But the con is that it can be quite time consuming. Sometimes patients are there for the entirety of the day, for hours, and can be a bit expensive. So how is Mohs surgery done, and what is it specifically? So this is a schematic about how Mohs surgery works. So first, the dermatologic surgeon will numb the area. And you can see here, then after they numb the area, they'll remove the visible tumor that they can see. And then they process this tissue and go in an office lab. So there's an on-site lab where the tissue is processed, and then the surgeon is able to look at the tumor itself under the microscope and see if there's any remaining tumor left. While all of this is happening, the patient is bandaged and sent back to the waiting room. So if the surgeon determines that there is no remaining tumor, they'll suture the open wound and send the patient home. But if there is tumor remaining, as you can see in step 2, they'll go back and remove more tissue, but just in the area where there's tumor remaining. They don't take a big wide margin around the whole thing again. They are very specific, use the findings under the microscope to localize where they go back for the remaining tumor. And this process was repeated as many times as is needed to remove the entire tumor. And so, as you can see, depending on how many times this has to happen, it can be quite time consuming. But it's very helpful for areas that are cosmetically sensitive, such as the face, because it allows for the least amount of tissue to be removed, while also ensuring that the entire tumor is removed before the wound is closed. And so I wanted to touch upon a much less common but very aggressive form of non-melanoma skin cancer called Merkel cell carcinoma. So Merkel cell carcinoma is most common in fair-skinned elderly patients, and typically happens on the head and neck, but can happen on other areas of the body. And we know that a suppressed immune system is also a very significant risk factor for Merkel cell carcinoma. It is a very aggressive skin cancer, unlike basal cells and squamous cells, which are not as aggressive, meaning Merkel cell carcinomas have a tendency to spread to lymph nodes and other organs. And interestingly, we've figured out that Merkel cell carcinoma is actually caused by a virus, the Merkel cell polyoma virus, in about 80% of cases. Most commonly, it presents as a rapidly growing pink-purple nodule. And these are just a few examples of that. You can see that they can grow pretty quickly, and they can have this kind of also translucent, but sort of like a deeper purple hue. Okay, so how do we treat these? So how we treat Merkel cell carcinoma depends on how far it has spread within the body. So if it has spread to the organs of the body, then it would consider immunotherapy or a clinical trial, which Dr. Ma and Dr. Pavlik will also we'll discuss much further with in this session. But if it hasn't spread widely, then we consider excision with a large margin of normal tissue around the cancer site, followed by a sentinel lymph node biopsy in most patients. So to explain a sentinel lymph node biopsy a bit more, we have a collection of lymph nodes, which are immune tissue. And we have these lymph nodes that all over our body, but they're concentrated in certain areas, or what we refer to as basins, in the underarms, in the groin area, in the neck. And a sentinel lymph node is the first lymph node which cancer cells are most likely to spread to from a cancer. So a sentinel lymph node biopsy allows us to remove just those lymph nodes by identifying them using a radioactive dye. So that dye is injected. The sentinel nodes take up that dye. The surgeon can use a probe to identify them and surgically remove them. And then those nodes are then sent to the pathologist and looked at under the microscope to see if there is remaining tumor cell, or if there's any tumor cell in there, and if the Merkel cell had spread to the lymph nodes. So this is more of a diagnosis than it is a treatment. But it's a helpful way to identify whether or not it has spread to the nodes. So then usually patients also will receive radiation therapy to the site of the Merkel cell carcinoma on the skin. And then further treatment depends on whether or not there was cancer on the sentinel node biopsy. So if there was no cancer detected, then oftentimes there'll just be radiation to the lymph node area that was sampled. So maybe the right underarm. And if there was cancer detected, maybe they'll go back and take out all of the lymph nodes in that one area. Obviously, treatment is going to be, patient specific and a little bit more nuanced than this often, but these are sort of the general guidelines for how Merkel cell carcinoma is treated. And then I will take a little bit of time briefly to talk about how we can prevent skin cancer. If it wasn't already obvious from my talk, protecting your skin from the sun is the best strategy to help prevent skin cancers. Sun avoidance is particularly important, and knowing when to avoid direct sunlight. So during midday at noon, the sun's rays have the least distance to travel through the atmosphere to get to us on Earth, and that's when the sun's rays are strongest and most high risk. So it's best to avoid direct sunlight between 10 a.m. and 2 p.m. when the sun's rays are the strongest. And then sun protective apparel is one of my favorites, and it's more effective at decreasing our risk of sunburn than sunscreen is. And the reason is clothing is constant. So it doesn't require reapplication, and the protection level doesn't decrease with time over the course of wearing it in one particular day, unlike sunscreen. So I always encourage my patients to really heavily rely on UV protective or sun protective clothing. So loose fitting, you want to look for loose fitting, dark colored fabrics with chemical UV absorbers or dyes, and you want to look for the designation UPF 50, and ideally cover yourself as much as you can, long sleeve shirts and pants. And these often you can find very light fabrics that are not overly hot. So this is a really great option, especially if you're going to be outside for a long time. And then never forget your wide brim hat and sunglasses, and you want at least 3 inches on the brim of your hat to get the best circumferential protection. And patients also often ask me, where do I buy these? Where do I buy UV protective clothing? And really you can find them anywhere. There are a ton of brands. They're very easy to find, even on Amazon or at Target. You just have to look for UV or sun protective clothing. And then finally, we inevitably have to wear sunscreen because we can't cover our whole body in UV protective clothing. So we have to wear sunscreen on our face and all areas that are exposed. So I often tell my patients to wear broad spectrum sunscreen, which means it covers both UVA and UVB rays, and at least SPF 30 or higher. Sometimes I recommend a little bit SPF 40 or 50, just because people tend to under apply sunscreen. So if you use a slightly higher SPF, you can compensate for the tendency to under apply. You want to apply it 15 to 30 minutes before going outside to all exposed skin, and apply at least 1 shot glass to the entire body with each application. So that oftentimes surprises people. That's a lot of sunscreen. So you really have to be generous with your application to get the SPF that's written on the bottle. You want to reapply every 2 hours. This is really, this is really important. And I think oftentimes where people struggle a bit, and you really want to apply it after swimming or sweating. And if you're going to use it in the setting of swimming or sweating, you want to make sure you have a waterproof sunscreen. I tell my patients to apply sunscreen every single day on exposed areas. So if you make it a habit, then you don't even think about it. And most of us are outside at least for part of the day, whether or not it's going to work or running errands. So when it's cloudy, even up to 80% of the sun's rays reach the earth, and you can get a sunburn even when it's cloudy. So just because it's cloudy doesn't mean you don't need sunscreen. And when to apply it. So if you want for the face, you want to apply it after moisturizer, but before makeup. So the more you build a habit, the easier it'll be. And then I often get asked, what is the best type of sunscreen? And truly the answer is one that you will actually use and use consistently. So just to summarize, exposure to the sun is our biggest risk factor for non-melanoma skin cancer, and our sun protection is our best way to prevent against it. There are 3 main types of non-melanoma skin cancer, basal cell and squamous cell being the most common. When you think of basal cell, I want you to think about pink and pearly. With squamous cells are more red and scaly, and Merkel cell carcinomas are much rarer, but those are the more pink, purple nodules. There are many different treatment options that depends on the type of skin cancer that you have, the location, and how aggressive that skin cancer is. And it's always a discussion with your doctor about what the best treatment option will be for you. And things you always want to tell your doctor about, not wait for your skin check, but tell them right away if you develop a new or changing lesion, a wound that's not healing, or any lesion that spontaneously bleeds, is itchy, or is painful. That's everything I've got. Thank you so much. Appreciate being here.